Thank you. So challenging case, pre-existing anterior and posterior capsular rupture. So if you see here, this 25-year-old gentleman came to us with a trauma, and very closely on the slit lamp examination, I could see there was a scar on the cornea and there was a break, both anterior and the posterior capsule. So the plan was simple, to go anteriorly, and this is the posterior capsular rupture if you see here. So I make two side port entries, push in the trypan, stain, and push in the viscoelastic. Now, this is the breach in the anterior capsule. So a lot has been talked about the oval rhexis. So yes, my plan was to do an oval rhexis here and try to include this break in the anterior capsule within the anterior capsular rhexis. So important here is that this break is covered under or within this anterior capsular margin. That's number one learning. And yes, you have to be ambidextrous to fashion an oval capsular rhexis here. So I begin, this is how I initiate, go in with microrhexis forceps, and very carefully, I'm trying to draw an oval capsular rhexis. At any moment of time, I don't allow my chambers to shallow. And here I exchange, I become ambidextrous. I try to create an oval rhexis, very carefully trying to fashion to include that breach within the capsular margin. So yes, successfully, I am able to achieve that anterior capsular rhexis. Now, plan B is very simple. 25-year-old gentleman, soft nucleus, quite aspirable. So just watch my left hand. The irrigation remains right on top of the nuclear fragments. And with my right hand, I'm trying to cleave. I'm trying to separate the nuclear fibers all 360 degrees. So I'm trying to create a saucer. And this saucer would sit right on top of the posterior capsular break. Very carefully, you'll realize a large break in the posterior capsule becomes quite visible. So yes, if you see carefully, there is a break. It's a large break. It's a large break there. Am I audible?
Yes, yes.
So watch carefully. As Dr. Namrata rightly pointed out, my left hand goes on top of the iris. I don't allow my chambers to shallow. The dispersive goes in and tries to create a barricade so that the vitreous doesn't prolapse. But still, I push in triamcinolone, try to strain and check out. And if I feel there is any residual tags, with this limited anterior vitrectomy, I can remove. So limited anterior vitrectomy with triamcinolone staining is always a must. Now, the third step is I'm trying to fashion this into a round regular posterior capsular rhexis to make the lens back complex very stable. So a very careful with my microrhexis forceps, I'm trying to break and convert into a PCC. And again, a limited anterior vitrectomy helps me to take away the tags. The viscoelastic further goes in. The lens of my choice here would be a 3-piece lens. I push the lens directly inside the bag very carefully. I can use a Cook lens to support, and just watch. This is what I do. I do a posterior capture. The optic goes behind the posterior capsule with the haptics remaining right inside the bag. A very stable lens back complex can be achieved in these patients. Step 4, sometimes this lens pops out. So watch my left hand, the irrigation remains on, and I'm trying to hydro-stitch the wound with the chamber being maintained. So I'm again ambidextrous here. My wounds are being stitched, and again this side port, I don't let the chamber shallow, and very gently and elegantly, I try to hydrate the wounds and maintain the chamber so that the lens doesn't pop out. This is the day 1 picture, and the patient regains a good vision. The lens is very clearly in the bag and stable. Thank you very much, Dr. Chitra.
Brilliant video, Dr.